Ever find yourself feeling, I don't know, a bit short of breath after cleaning out the birdcage? Or maybe after spending some time in the hot tub? You might just brush it off, right? But what if?
Yeah.
What if it's actually a sign of something more serious going on in your lungs?
Yeah, that's a really common scenario, actually. And it sets us up perfectly for today's deep dive. Extrinsic Allergic Alveolitis. You might also hear it called Hypersensitivity Pneumonitis, or just EAA for short.
EA. Got it.
Basically, think of it as your lungs getting pretty inflamed because they're reacting to something specific you're breathing in regularly.
Okay, so lungs reacting badly to inhaled stuff. What kind of stuff are we talking about? And what's actually happening inside the lungs?
Exactly. It's an immune system overreaction.
Yeah.
We're mainly talking about a type 3 hypersensitivity response happening right down in the alveoli, those tiny air sacs and the lung tissue around them.
Type 3 hypersensitivity.
Right. So repeated exposure triggers this immune reaction, which leads to inflammation, allergic symptoms, and potentially, over time, scarring or fibrosis. It's like your lungs are putting up this huge fight against something they see as an invader.
Okay.
And what's interesting about that type 3 part, where these little clumps of antibodies in the inhaled substance form, is that it often explains why symptoms might pop up, say, 4 to 8 hours after you've been exposed. It's not usually immediate, like some allergies.
Ah, okay, that delayed reaction is a clue then.
It can be, yeah.
Yeah.
And there's also a delayed cell-mediated hypersensitivity component, too,
Yeah.
involving specific immune cells, which sort of adds fuel to the fire.
So like a double hit for the lungs. What are some common triggers? Can you give us some specific examples, things people might recognize?
Absolutely. Some have quite memorable names, often linked to where you encounter them. Bird Fancier's lung is a classic that's from proteins in bird droppings.
Right.
Then there's farmer's lung, from inhaling mold spores in damp hay. Malt worker's lung, that comes from mold called Aspergillus clavatus, found in malted barley.
Okay.
And mushroom worker's lung is linked to certain bacteria-like organisms, Actinomycetes, in mushroom compost.
Those names definitely help picture it. Moldy hay, bird droppings. Makes
Yeah.
sense. Is there a quick way, maybe for exams, to remember some of these?
Yeah, here's a little memory trick. It's a bit weird, but picture this. A farmer, okay? He's got a bird sitting on his shoulder.
Okay.
He's drinking a malt beer, and he's checking on his mushrooms. Farmer, bird, malt, mushrooms. It links a few of the big ones together.
Huh. I like it. Quirky, but memorable.
And pathologically, when we look at the lung tissue itself, we often see this pattern called diffuse granulomatous inflammation. That's just how the immune cells group together. But the absolute key thing for management, avoid the trigger. Avoid the allergen.
Right. Stay away from whatever is causing the irritation. But why do some people get this reaction when others breathing the same air don't?
That's a crucial point. It really seems to come down to individual susceptibility. You need the exposure, yes, to those organic things like mold or bird proteins or even some inorganic dusts or chemicals,
Okay.
but you also seem to need a kind of predisposition. There's likely a genetic component involved. The range of antigens is pretty broad: molds, bird droppings, animal dander, dust mites, certain chemicals.
So it's not just the exposure. Some people are just more prone to react.
Exactly.
Yeah.
And the immune response itself involves both those T cells, that's the cellular part, and antibodies, which is the humoral part.
Okay, so it's complex. What specific things put someone more at risk then?
We can group the risk factors. Occupation is a big one, as you'd expect. Farmers, bird keepers, woodworkers inhaling dust, people working with certain chemicals.
Makes sense.
Then having other lung problems already might make you more vulnerable. And as we said, that individual genetic makeup plays a role. Oh, and interestingly, even using a hot tub could be a risk if it's not maintained properly.
Hot tubs? Really? How?
Yeah, you can inhale aerosols, tiny water droplets containing certain bacteria or molds if the water isn't clean. It's sometimes called hot tub lung.
Wow. Okay. Good to know. So we've got the triggers, the risks. How does this damage actually happen in the lungs step by step?
Right, so it kicks off with inhaling the antigen. That sets the immune system off, starting inflammation. Immune cells like lymphocytes and macrophages rush in. Exactly. But they release substances that cause more inflammation and can actually damage the lung tissue itself. If you keep getting exposed again and again, this inflammation can become chronic. That's when you risk getting fibrosis, the scarring, and more permanent lung damage.
And that involves both types of hypersensitivity we mentioned?
Yes, both the cell-mediated and the immune complex reactions are driving this. And again, there's probably that genetic tendency making some people more likely to go down this path. There's even some thought that maybe certain viral infections, like COVID-19, could potentially mimic or even contribute to EAA sometimes.
Interesting. We mentioned farmer's lung, bird fancier's lung. Any other common occupational or hobby-related ones we should really lock in?
Yeah, definitely worth reinforcing. So besides those two, think cheese worker's lung from molds on cheese. We mentioned malt worker's lung and mushroom worker's lung. Then there's hot tub lung again, and chemical worker's lung from various industrial chemicals. Knowing these specific names can really help pinpoint potential exposures.
Definitely sounds like something you shouldn't ignore. If someone has these breathing issues, what else could it be? What are doctors trying to rule out?
Great question. Differential diagnosis is key here.
Right.
It could be an infection, bacterial, fungal, viral, even TB.
Okay.
Or it might be related to connective tissue diseases that affect the lungs. Other types of pulmonary fibrosis need consideration, like idiopathic pulmonary fibrosis where we don't know the cause. Asthma, obviously. Sarcoidosis is another one. Histoplasmosis, a fungal infection. And even some medications can cause similar lung problems.
That's quite a list. Is there a mnemonic maybe to help remember the main differentials for exams?
There is one. It's a bit of a mouthful. I can't pant so hard, darling.
Okay, let's hear it.
So, I for infections, C for connective tissue disorders, P for pulmonary fibrosis, S for sarcoidosis, H for histoplasmosis, D for drug-induced lung disease, and A for asthma. I can't pant so hard, darling.
I can't pant so hard, darling. Got it. Okay, shifting gears a bit. How common is EAA, say, here in the UK?
Well, pinning down exact numbers is tricky. It's generally considered pretty rare, and the incidence really varies depending on local exposures,
Sure.
But there was a UK study that gave us some clues. They found 174 cases. Most of them, about 60%, were chronic. About a third were subacute, and only 6% were acute.
Mostly chronic, then?
Yeah. The average age was around 62, pretty equal between men and women.
Yeah.
What was really interesting, though, was that in almost half the cases, 48%, they couldn't actually identify the trigger. They called it cryptogenic.
Huh. So nearly half, they weren't sure what caused it.
Right. Occupational causes were next, about 28%, and metalworking fluid exposure was a big part of that. Non-occupational stuff like bird exposure, 15%, and drugs, 6%, made up the rest of the identified causes.
Okay.
And we should probably note that, potential COVID-19 related lung issues might affect these numbers going forward. But generally it's seen mostly in adults, it's rare in kids, and definitely more common in those high exposure jobs or hobbies like farming or bird keeping.
Right. Tends to be older adults linked to specific exposures
Yeah.
most of the time. So what are the actual signs and symptoms? How does it look clinically?
Okay, so we usually talk about two main ways it presents, acute and chronic.
Right.
The acute form hits you pretty fast, usually like 4 to 8 hours after exposure.
Yeah.
Key symptoms, shortness of breath, dyspnea, a dry cough, fever, feeling generally unwell like you've got the flu.
Okay, like a sudden flu with breathing problems.
Exactly. And here's a memory tip. Think dry flu with short breath for that acute picture. In really severe acute cases, it can get dangerous. Quickly think respiratory failure, cyanosis where the skin looks bluish, high fever, needs urgent attention.
Okay, scary stuff. What about the chronic form then? How's that different?
Chronic creeps up on you much more slowly over weeks or months of ongoing exposure. The symptoms are more persistent, things like feeling constantly tired, lethargic, still short of breath, maybe a cough that produces phlegm this time, losing your appetite, losing weight without trying.
More gradual, more systemic maybe?
Yeah, and in later stages of chronic EAA, you might see that bluish tint, cyanosis again, and also clubbing of the fingers and toes. These patients can develop low blood oxygen levels chronically, pulmonary hypertension, high pressure in the lung arteries, which can strain the heart.
Right, heart failure potentially?
Potentially, yes. And while stopping the exposure helps, the damage or symptoms might linger or come back easily if exposure happens again. People often notice they just can't exercise like they used to.
Okay, so acute is sudden, chronic is slow burn. How do you actually diagnose it? What tests are involved?
It's often a combination of things. Imaging is really important. A chest x-ray might show some haziness or patterns, but a high-resolution CT scan and HRCT is usually much better at showing characteristic changes in the lung tissue, maybe different patterns depending if it's acute or chronic.
HRCT is key.
It often is. We can also do blood tests to look for specific IgG antibodies against suspected antigens like bird proteins or molds. Finding them supports the diagnosis, but it doesn't prove it on its own.
Not definitive.
No. Other blood tests might show inflammation markers are up, but that's very nonspecific. Lung function tests, spirometry, are crucial. They often show a restrictive defect, meaning the lungs can't hold as much air. Oxygen levels might be low, especially when exercising. And the DLC-weed test, which measures how well oxygen gets into the blood, is usually reduced.
So tests showing restriction and poor gas exchange. Are there more invasive tests?
Yes, sometimes. In specialized centers, they might do an inhalation challenge test, carefully exposing you to the suspected trigger under supervision.
Wow, okay.
Another procedure is a bronchoalveolar lavage, or BAL. They wash out a small part of the lung and look at the cells in the fluid. In EAA, you often see lots of lymphocytes.
BAL for cell types.
Right, and sometimes the most definitive way is a lung biopsy, taking a small piece of tissue to examine under the microscope for those characteristic granulomas and inflammation. But honestly, it can be tough to diagnose. There isn't one single gold standard test.
So you piece it all together.
Exactly. The symptoms that dry cough, progressive breathlessness, feeling unwell, plus the exposure history, plus the results from imaging, lung function, blood tests, maybe BAL or biopsy. And we classify it as acute or chronic based on that history.
Okay, makes sense. So once it is diagnosed, how do you manage EAA? What's the treatment plan?
Number one, absolutely critical. Identify and avoid the trigger completely. That is the cornerstone of managing this. Get rid of the mold, rehome the birds, change the work environment if possible.
Avoidance first and foremost?
Always. For acute flare-ups, if symptoms are bad, you might need treatment to calm things down, maybe bronchodilators to open airways, or often corticosteroids to reduce that inflammation.
Steroids for the flare-ups?
Yes. And if someone's in severe distress, very low oxygen, cyanotic, that's a hospital admission straight away, they'll likely need oxygen therapy. For less severe or chronic cases, again, avoidance is paramount, and seeing a respiratory specialist is usually the way to go.
What about longer-term medication?
Corticosteroids, often oral prednisolone, are frequently used not just for acute episodes, but sometimes longer-term in chronic cases, especially if it's severe or progressing. But you still need to avoid the trigger even when on steroids.
Right.
If steroids are needed long-term or aren't working well enough or causing side effects, doctors might consider other immunosuppressants like azathioprine or mycophenolate mofetil. These are sometimes called steroid-sparing agents.
Okay. Any other drugs?
There's some limited evidence for drugs like rituximab or diflunomide in specific situations. And if there's already significant fibrosis, sometimes antifibrotic drugs might be considered, though that's more specialized.
And for the most severe cases?
In really advanced end-stage chronic EAA with severe fibrosis, lung transplantation might be the only option left to improve survival.
So avoidance is the main thing people can do themselves, right? Anything else non-prescription?
Absolutely. Avoidance is number one. If you can completely stop the exposure, the prognosis, especially for acute or subacute cases, can be excellent. If complete avoidance isn't feasible, well, then it's about reducing exposure as much as possible. That might mean better ventilation, wearing proper masks or respirators in risky environments.
Makes sense. What about the overall prognosis then? What's the likely outcome?
It really varies. It depends heavily on how much lung damage there is, how long the exposure went on, and crucially, how early it was recognized and managed with trigger avoidance.
Early detection is key.
Hugely important. If you catch it early, stop the exposure, get treatment if needed, the outlook could be quite good.
Yeah.
Especially for recovery of lung function in acute subacute forms. But, and this is a big but, chronic EAA, if it progresses to irreversible fibrosis, that's serious and can significantly impact lifespan.
So prevention is vital.
Absolutely. Workplace safety, awareness of environmental triggers. It all matters.
Okay. And are there specific long-term complications people should be aware of if they have EAA?
Yes. The main one we've mentioned is a chronic lung fibrosis, which can ultimately lead to respiratory failure. There's also a higher risk of getting secondary lung infections.
Okay.
Continued exposure just leads to more irreversible damage. That's why ongoing monitoring is so important. And severe HP does carry an increased risk of developing pulmonary hypertension and possibly even lung cancer down the line. And as we said, transplantation might be needed in the most severe situations.
Right. This has been incredibly informative. So just to quickly wrap up, EAA, or hypersensitivity pneumonitis, is the lungs reacting to inhaled triggers. Avoidance is absolutely central to management. Medications like steroids can help control inflammation, especially when it's severe, and catching it early makes a huge difference to the outcome.
That's a perfect summary, and it really underscores why thinking about your environment, your hobbies, your work, and any potential things you might be breathing in is so important. Simple safety measures can sometimes prevent a lot of trouble.
Really well put. And hey, if this deep dive has been useful for your MSRA prep, remember to check out pasttheemera.com. They've got loads more resources.
Yeah, and don't forget freeemera.com as well. Lots of valuable materials there, too.
Excellent. Thanks so much.